And it's live.
Okay, thank you guys all for coming today, whether you came by choice or you were forced. I'm happy you guys could be here. We're going to talk about end-tidal CO2, capnography. I think, I don't know how well everybody understands this, but it's not as clear and easy as you might think. There's a more to it than just patients breathing or not breathing, the tube's in or it's not in, okay? So it's an extremely valuable tool, and there's tons of uses for it. And I just want to make sure that everybody has a good understanding of what it is and how to actually interpret it, because you can really get confused very easily with what it's telling you and what you might think it's telling you. So the title of this presentation, A Tale of Ventilation and Perfusion, okay? So keep that in mind. So what does end-tidal CO2 tell you? Well, I think the thing that most people think about when they think end-tidal CO2 is ventilation, right? It gives you information on ventilation. It measures the concentration of carbon dioxide in an exhalation, okay? It's near equivalent of the carbon dioxide concentration that's in your alveoli. Makes sense, right? The carbon dioxide is coming from your alveoli right into the CO2 detector. That should be about the same. It's about 5 millimeters of mercury less than the blood concentration of carbon dioxide. Does that make sense? You guys understand why? Why? Anybody explain that?
Why is there, why there is a difference?
Yeah.
That's measured, arterial blood gases draws on dissolved gases, right? Would that be different?
Well, why is the blood concentration of carbon dioxide and the measurement that we're taking, the exhaled carbon dioxide, why is it different? Why is there a difference of 5 millimeters of mercury in the two? Does anybody know?
Is it the mixing of air in the dead space?
No.
Is it because your blood's producing the carbon dioxide at the source?
Well, blood is producing carbon dioxide, but how do things flow in the body? You go from high concentration to low concentration everywhere, right? You go from a gradient. You gotta have a gradient to make things move. So the blood carries this carbon dioxide. Blood can't get rid of carbon dioxide unless it diffuses into the lungs. And in order to get that carbon dioxide from the blood into your alveoli, you have to have a concentration gradient where it can go from high to low, diffuse into your alveoli, and then exhale out. So that's why there's a slight difference, but 5 millimeters of mercury between your blood and what you're getting in your CO2 detector, that's pretty good. You know, that's not a significant difference. So this is your end-tidal CO2. This is your standard waveform that you'll see. Okay, you have your baseline, which it should be at 0, right? Your baseline indicates inspiration. Okay, so when you're inhaling oxygen, right? You shouldn't be inhaling any carbon dioxide unless you're breathing from an exhaust pipe or, you know, from some poison substance. But when you're inhaling, there should be no CO2 going in. So you have a value of 0. And when you start exhaling, all of a sudden it jumps up, because what do you do when you're exhaling? There's carbon dioxide coming out, and that's what you're detecting. So you'll see it jump up very quickly. For the most part, you're breathing, you see a slight uptrend in your plateau, and the reason is the initial air that's coming out is the air that's in your trachea and your bronchioles. And your trachea and your bronchioles, they don't diffuse carbon dioxide into your breath. Only your alveoli do. So that's why you start off with slightly lower carbon dioxide level, and then at the peak, this is all the air that's coming out of your alveoli. That's your end-tidal CO2 value right there, okay? And then as soon as you're done exhaling and you start breathing back in, it jumps quickly back down to 0, okay? So keep that in mind. So ventilation. So that's what a normal capnograph should look like. Should have rectangular waves. The normal value is between 35 to 45. Okay, and this is kind of washed out, but this is a normal capnography waveform, right? If you're hyperventilating, you're breathing too quickly, you're taking quick, short, shallow breaths, and you're breathing very quickly. So you're gonna blow off a whole bunch of carbon dioxide. The alveoli don't have time to build up enough carbon dioxide because you're blowing it out very quickly. So what happens? You get a low end-tidal CO2 value. It's usually below 35, depending on how quickly they're breathing. Now, if they're hypoventilating, they're not breathing very quickly, they're breathing very slowly. What's gonna happen? That CO2 is building up. When you finally exhale out, you're gonna have a much higher than normal value, right? So you're gonna see these much higher than normal waves. They're gonna be a lot longer. And what you might also see, this one doesn't show it, but you might have a very long baseline of 0 because patient's not taking in very many breaths. So you might see a very long baseline of 0, and then you'll see it go up, and you'll have a value that's greater than 45. So how do we use all this, ventilation stuff? All right, whatever. It's breathing, they're in, out. How do we use this? Well, there's lots of uses for it from a respiratory standpoint. First of all, and this is the most common use that everybody should be using it for, is airway placement, right? You want to check to see, is my endotracheal tube in the right place? So if you've got the endotracheal tube in the trachea, you're going to get end-tidal CO2 waveforms, and you're going to have a value, right? If you're in the esophagus, initially you may have a waveform, but after a few breaths, it's going to go flatline, okay? And if that's the case, you need to immediately remove that ET tube because you have to assume it's not in the right place, okay? Why do you see, I thought there's no carbon dioxide and stuff, why do you see? Well, depends, if you had a patient that just drank a Coke, there's some CO2 in their stomach and you actually will see it, but this is the pattern you're gonna see. You might even see that, I don't think this is the norm if you intubate the esophagus. You're not gonna see nice big rectangular waveforms like this. But let's say you do, for some reason, what you're gonna see is you won't get past 6 breaths before it's gonna flatline out. And you're gonna see them decrease to complete 0. So keep that in mind, okay? Watch this, don't just assume, okay, I had the end-tidal CO2, so I'm in the right place. See what it does. After you get about 6 breaths, you better make sure you still have end-tidal CO2. Make sure that it hasn't gone flatline or it's not starting to decrease down to complete 0, but it will go completely down to 0 if you're in the esophagus. So keep that in mind. The other thing that it'll detect, so what happens after you put the endotracheal tube in, you get it in the trachea, you put the tube taper on, right? You put the tube taper on, it's supposed to keep the tube from coming out or dislodging or anything. Well, what if the patient's moving around, he's pushing on the tongue, or he's doing something funky with his, this guy can tie cherry stems into knots with his tongue. What if this guy dislodges the ET tube inside of his oral cavity, but with the tube taper on, you're not going to see it move out of place, right? You might not necessarily see it move from the lip, but just the end curvature of it might be slipped out of place. Well, this is another reason why end-tidal CO2 is great, because if you're in the trachea and you're fully getting your full exhalations, you're going to have these nice rectangular waveforms. As soon as that endotracheal tube dislodges, or if it's not fully in the trachea, you're going to start seeing some changes in your waveform. You'll start seeing it where it's not detecting the full exhalation, and it's cutting off. You see, it starts off almost normal right here, and then boom, and all of a sudden doesn't do its normal rectangular pattern like it should. And that's because that tube is probably no longer in the trachea. It might be sitting right above the vocal cords. It may be completely out. It's in a place where it's still getting some of the exhalation. It's still detecting some of the CO2, but you can see it's not getting that nice rectangular waveform like you should be seeing on a normal exhalation and a normal airway placement. So if you got that tube in place and you're going down to Galveston with that patient, you need to be watching the end-tidal CO2, because all of a sudden you see this, you got a problem. Your tube's not in place anymore. Something's wrong with it, okay? And it's very common. You can have a tube that's sitting it could be right above the cords. The tip of the endotracheal tube can be right above the cords or not seated very well. You may not see the O2 sat drop. You might still hear good lung sounds bilaterally, so you can't really depend on that, because sooner or later what's going to happen is that thing's not going to be sitting right above the vocal cords. It's going to move out of place some more, and now all of a sudden you're going to think, well, it was in the trachea, I don't know what's going on, maybe it's suctioning in, but you're out of place. So that's very useful, because there's nothing else. You don't have a chest x-ray, you don't have anything else that can tell you this, so keep that in mind. The other thing you can use it for, ventilation adequacy. So everybody's had these patients where, you know, they're lethargic, got altered mental status, they're real somnolent, maybe they've overdosed on something, has a GCS of 4 or 5. Man, do I intubate this, or am I going to intubate this patient? And the doctor decides it's going to be all over me for intubating the patient. I said, no, you know, what do you do with this? Should I be intubating the patient? Well, the O2 set's 98%, so they must be breathing okay if their O2 sets are 98%, 100% on room air. Well, not necessarily, because people can have enough oxygenation going on, but that doesn't mean they're breathing appropriately, right? If I'm taking very shallow breaths and I'm only breathing 8 times a minute, I might still have an O2 set of 100%, but that doesn't necessarily mean that I'm ventilating properly. I'm not blowing the CO2 off properly. You know, if you have a normal end-tidal CO2, that means they're getting a full adequate breath and they're exhaling adequate carbon dioxide. If your end-tidal CO2 starts to increase, let's say you pick up this patient and you're like, well, his sats are good. I think he's okay. I don't think I need to intubate him. But what if you're watching him, his end-tidal CO2 is 38, and as you're transporting, you start to see that end-tidal CO2 go up? What's going on? If it's going up, that means he's starting to hypoventilate. They're not taking good deep breaths. If he overdosed on something, maybe he's getting deeper into the overdose and he's becoming more sedated from the 100 Xanaxes that they took. And what you're gonna see is the end-tidal CO2 is gonna start going up before you even see a drop in the O2 sat. Okay, so if you're going from a normal end-tidal CO2 and now all of a sudden it's climbing to 50, it's climbing to 60, that means this breathing is slowing down way too much. You may not see that O2 sat drop for 2-3 minutes, but you better go ahead and get your bag out and you better start supporting them, because they're about to start desaturating on you, okay? End-tidal CO2 starts changing before any of the other vital signs start changing, before blood pressure, before O2 sat, before the patient loses their pulse. So very, very unique tool. The other thing, let's say you got a patient and they've overdosed on aspirin, okay? Patients that overdose on aspirin, they've got all kinds of acid-base disorders. They're very acidotic from the aspirin. And what are they doing? They're hyperventilating, okay? Why are they hyperventilating? Well, because they've got a lot of acid in their blood. Their body's producing a lot of carbon dioxide. They're blowing it all off, trying to get that acid level down. Well, what happens if you're breathing 50 times a minute eventually? If you've been doing that for 8 hours, probably not even 8 hours, you've been doing that for 1 hour, you're gonna start getting tired. So initially you may come to this patient and they're breathing, you know, 30, 40 times a minute, and you hook them up to the end-tidal CO2 and it's low. It's down to 15. Well, you want them to be hyperventilating. They're doing what their body's supposed to be doing, but what happens if you start seeing it go up? That means they're starting to get tired. Their breathing's starting to slow down. They're not breathing as effectively anymore. They're starting to get tired. They're gonna start crashing on you, okay? So you need to keep that in mind. DKA patients, what do DKA patients do? They breathe fast, right? What do asthmatics do? They're in asthma exacerbation, what do? They're breathing very fast. What do they say about an asthmatic? If they're not breathing fast, that's a bad sign, right? So that's why the end-tidal CO2 is helpful in these kind of situations. You'll oftentimes see the end-tidal CO2 change before the O2 sat. And this is something that they use in the hospital. Of course, we don't be doing this, but if, let's say, it does apply sometimes to overdoses. We use it in procedural sedation to know if we're keeping track of them okay, if they're breathing okay, if we're putting them in too deep or not. So keep that in mind, okay? So the other thing, and this is, I think this kind of confuses people because if they're acidotic, shouldn't their end-tidal CO2 be low or should it be high? So the one thing I try to tell people is end-tidal CO2, don't try to correlate it with pH and acidosis and whatnot. Try to focus on determining what's going on with your ventilation and your perfusion. When you start trying to think about, oh, well, the end-tidal CO2 is low, so that means, you know, they're not breathing fast enough, and that means I need to bag them more. Try not to get into that because that's really going to confuse you and mess you up to the point where you're not going to be able to tell, wait a minute, do I need to bag more? Do I need to bag less? Do I need to get bicarb? What do I need to do with this patient? So try not to get into the jungle with, okay, wait a minute, trying to figure out, oh, this patient's got to be acidotic because the end-tidal CO2 is this, and I need to give them bicarb because it's going to completely mess you up. That's not what end-tidal CO2 tells you. It doesn't give you the pH. It tells you what's going on with the ventilation, and it tells you what's going on with the perfusion. So keep that in mind. So what else can you do? Well, it can also give you a little bit of information on the patient's respiratory status. You come to a patient that's in respiratory distress. Let's say you get to a patient, how many of you guys have had a patient that's got a history of CHF, has a history of asthma or COPD, and they're swelling in their legs, and when you listen to them, they're wheezing? Well, are they wheezing because they got pulmonary edema, or are they wheezing because it's their asthma that's firing up, that's exacerbating on them? What do? Do you give them Lasix? Do you give them a breathing treatment? Do you give them both and hope one of them works? What do? You know? Well, this is an interesting feature of end-tidal CO2. End-tidal CO2, the waveform, will let you know what's going on, okay? If you have a obstructive process going on, by obstructive process, that's asthma, right? What happens is asthma, their bronchioles constrict. What you'll see is their waveform will change from the normal rectangular shape to what's called a shark fin pattern, okay? And why does it do that? Well, what's happening? Their airway is going from being wide open to blocked off, right? So when they start breathing out, they can't just breathe out a full breath. It takes a while for them to get all of that carbon dioxide exhaled out, and so you see a slow uptrend in the carbon dioxide level. You don't just see it shoot straight up like you would in a normal patient because their airways are blocked, right, with bronchial inflammation. So what you're going to see is if you got a shark fin, you hit that patient out, wait a minute, this isn't their CHF, this is their asthma. I need to give them a breathing treatment, right? In asthma, COPD, even if you have a patient that's intubated, and let's say they get a big mucus plug that's partially blocking their endotracheal tube, you'll see this similar pattern. If the patient has CHF or there's pneumonia, they'll still keep their normal rectangular waveform. Okay. So the second thing end-tidal CO2 tells us about is perfusion. Okay, so we talked about how you can use end-tidal CO2 with monitoring respiratory status, knowing how you intubate it, figuring out is this a CHF wheeze or an asthma wheeze. The other thing that it tells you is perfusion. Okay, nothing about pH. Remember, we don't try to figure out what's going on with the pH and we need to give bicarb or whatever with end-tidal CO2. We use it to figure out what's going on with their breathing and what's going on with their circulation. And then later in this presentation, I'll show you guys how we can kind of tie it all together. So how does it tell you information about cardiac perfusion? Well, like I said earlier, how does carbon dioxide get to the lungs? Well, it's carried in the blood, right? Your whole body is producing carbon dioxide and it dumps it into the blood. You gotta have circulation to get that blood to the lungs, and then it diffuses into the lungs and then it blows off. So you gotta have three things to have carbon dioxide removal. You gotta have a pair of lungs, first of all. You gotta have blood, and you gotta have circulation to have that blood moving through the body to get it to the lungs. So blood is circulated through the lungs, allows carbon dioxide to fuse into the alveoli, and then it gets exhaled. If you don't have cardiac output, you don't have an end-tidal CO2 because that carbon dioxide isn't getting moved to the lungs to get blown off, right? That makes sense? If you see decrease in your circulation, you pick up a patient, they're hypotensive, what's going on? Their blood isn't pumping through their body very effectively, right? They're not getting very much blood flowing through their lungs like a normal person would. What are you gonna see? You're gonna see a drop in their end-tidal CO2, right? Why? Not because they're hyperventilating, because they're not getting enough perfusion to their lungs. So you see how it can become a little bit tricky? So if the end-tidal CO2 drops to 0, what's going on? Better check the pulse, okay? Especially if you don't have an endotracheal tube in place. You better check a pulse, or you better be getting that endotracheal tube out of there. So hyperperfusion. When you got a patient that's not perfusing properly, they're hypotensive, they're in cardiac failure, you're gonna see a drop in the end-tidal CO2, and the waveforms are gonna be a lot smaller. There's not a lot of CO2 being delivered to the lung, so the value's not gonna be high. You might see, and this isn't the most common thing, but you might see little short tombstone type waveforms. And if you see this, you wanna check the blood pressure, because a lot of times, like I was saying, end-tidal CO2 will drop even before the blood pressure does, okay? Cardiac arrest. You got a patient that's in cardiac arrest, you're not gonna have a waveform. So how do we use end-tidal CO2? Well, first of all, we can use it to determine how well we're doing chest compressions, okay? If you're doing chest compressions, you're gonna have a waveform, first of all, okay? You want that waveform, you want an end-tidal CO2 of at least, some people say 10, some people say 15, but if you're doing good chest compressions, you should have at least an end-tidal CO2 of 15, and that's been shown that that's an adequate chest compression that's perfusing the patient. If you're doing chest compressions and your end-tidal CO2 is 5, you need to push harder, push faster, or you need to get somebody else to do the chest compressions. If it's less than 15, you're not doing it right. You need to get hard. And it's another way to keep track of, okay, is this person starting to get tired? You get a guy down there and he's doing chest compressions and they're starting off with an end-tidal CO2, 18, 20, 25, great. What happens after doing that for 3 minutes? The guy's getting tired. You see that end-tidal CO2 start going down and now he's not getting above 15. All right, it's time to switch. Okay, so that's another way you can use it. If you're doing chest compressions and there's no waveform, then you need to check the placement of your airway, okay? If there's an ET tube in place, you need to check it and make sure it's in the trachea. If there's an I-gel in place, you need to make sure there's not something blocking it or it's seated properly in its appropriate place. And of course, check your tube, make sure your tubing hasn't become disconnected from the monitor. If you're doing compressions and then all of a sudden you have an end-tidal CO2 20 and then it shoots up to 30, 40, you got ROSC back, okay? Because what happens when you get perfusion? You have end-tidal CO2. So you'll see it jump up, and you'll oftentimes see the end-tidal CO2 jump up before you'll even feel a pulse. So keep that in mind. And then the one thing that's been shown in multiple studies, if you've been doing high-quality CPR with an end-tidal CO2 of 15 with your efforts, you've been doing this for 20 minutes, and when you stop, your end-tidal CO2 drops to less than 10, there's basically a 0 chance that patient is going to survive. So, something to keep in mind. So this is what ROSC is going to look like. You'll have a waveform there, and then all of a sudden it's going to spike up. I got ROSC back on this patient. So reasons for a low end-tidal CO2. Well, the first one we talk about hyperventilation, right? Patient's breathing too fast, they're blowing off all this carbon dioxide, you're gonna have a low end-tidal CO2. Your endotracheal tube is displaced. That's gonna cause it, right? If you got a hypotensive, hypoperfused patient, that's gonna cause them to be low. If they got a PE, what happens? That blood can't get through the lungs like normal because there's blood clots blocking it. They're gonna have a low CO2. Apnea, patient's not breathing, you're not gonna have carbon dioxide coming out. If there's a total airway obstruction, you got a big mucus plug stuck in that endotracheal tube or even in their trachea or something, they're not gonna be able to exhale CO2. They may not have a CO2 reading. Obviously, if your apparatus is malfunctioning, that's another reason. Or if you have an endotracheal tube cuff leak, your cuff is popped or there's leaking, a lot of that exhalation is going to go around the tube and the CO2 detector is not going to pick it up. might give you a low reading. And you'll get an abnormal waveform. So keep that in mind, waveform and the number. Reasons for a high end-tidal CO2. Well, if you got a patient that's running a fever, they tend to have a high end-tidal CO2. Their body's producing a lot of CO2. Hypoventilation, patient's not breathing, they're building up a lot of carbon dioxide in their lungs, it's gonna be high. If they're rebreathing, if you got a patient that let's say they're on the vent or you're bagging them and you're not giving them enough time to fully exhale, what's gonna happen? All that carbon dioxide is not getting blown off. You start seeing that carbon dioxide level go up. You need to stop bagging so much and give them some time to exhale. ROSC, you go from low to high, check your circulation. You might have got a pulse back if you're in cardiac arrest. Partial airway obstruction. So how does that make any sense? Let's say you got a patient that's intubated and just half of the endotracheal tube, let's say they got a mucus plug, but they're still getting some air out. You're gonna see a difference in their waveform. You're not gonna have that nice rectangular waveform, but you might see a high end-tidal CO2. Why? Because that mucus plug is letting some of the carbon dioxide exhale, but a lot of it is getting blocked down into the lungs and it's just building up. Does that make sense? You have a partial obstruction. Apparatus malfunction again. And administering sodium bicarb. What? I thought bicarb, you know, that's supposed to neutralize pH. That's what I said. It's gonna neutralize your pH, but remember what I told you, do not try to interpret end-tidal CO2 to pH of what's going on with the patient. If you give somebody bicarb, don't be surprised, your end-tidal CO2 will go up. And the reason it's gonna go up is because bicarb causes a sudden conversion of a bunch of hydrogen chloride ions in your body into carbon dioxide, and all that stuff's gonna get dumped into the lungs. So that's just something to kind of remember, because it's gonna totally throw everything off. That's why I hate giving bicarb. You wanna resuscitate the patient unless you got a terribly acidotic, hyperkalemic patient that's coding on you, obviously. But when you do, don't let it fool you. That's why it went up. So put it all together, all right? You got ventilation, you got your perfusion. I'm totally confused. I thought I understood. Now he just messed me up more than ever. I don't understand anything anymore because nothing makes sense. So just remember, end-tidal CO2 is an adjunct, okay? It's not the end-all, be-all, tells you exactly what's going on. Use it, but then look at your patient, okay? You have to do the hard part. You have to actually think. It's just a number, but we all have to think. So use your other vital signs. Look at your physical exam. If your patient's awake and alert, talk to him, see what's going on. Observe your patient. So there's a couple examples here. If you have a low end-tidal CO2, right? It's really low, and your patient is not hyperventilating, what do you need to do? Check a blood pressure. Make sure the patient is perfusing. Make sure there's pulses there. Make sure their blood pressure isn't in the toilet or their heart rate's not 20. Because remember, ventilation and perfusion is required to have an end-tidal CO2, right? What if you have a low end-tidal CO2 and your patient is hyperventilating? If they're breathing 50 times a minute, yeah, you're gonna expect their end-tidal CO2 to be low, right? So what do you do about that? Again, check for hyperperfusion, because if they're hypotensive and they're hyperventilating, their end-tidal CO2 is still gonna be low, but you need to troubleshoot and make sure, hey, you're not missing that blood pressure of 60s because you're like, oh yeah, he's breathing too fast, I don't need to check a blood pressure, he's probably fine. No, check a blood pressure, check your patient. And if they're hyperventilating, remember what I said, who hyperventilates? Your acidotic patients, right? Your DKs, your aspirin overdoses. Look for potential causes, check a finger stick, what's your sugar? Oh my God, his sugar was 8,000. No wonder he's breathing so fast. I need to make sure he keeps breathing this fast, because if he stops breathing this fast, that means that PA is going to get more acid. I know I keep telling you guys not to associate it with acidosis, but hyperventilation, why do they hyperventilate? Because they have some acid buildup. So, you know, don't get too deep into the woods with it, but kind of learn the basics. What if your end-tidal CO2 is high? Okay, that means they could be hypoventilating, right? They're not breathing fast enough. Perfusion doesn't necessarily cause it to go up high, but if you're sitting there with an end-tidal CO2 of 70, the patient may not be breathing very much. So look and see if they're hypoventilating. If they are, bag them, assist their bagging, okay? Or if you just gave them bicarb, expect it to be high, right? In a head bleed, let's say you're transporting a head bleed and they've intubated the patient, you want that patient to keep a normal end-tidal CO2. So use the end-tidal CO2 to make sure you're not hyperventilating them or hypoventilating them, because either of those is bad for head bleeds. You want that end-tidal CO2 to stay between 35 to 45. Look for changes in your waveform. Look at your waveform. You know, you pick up an asthma COPD patient, they're shark fitting. Their waveforms are shark fitting. Give them a breathing treatment and look and see if their waveform goes back to a rectangular waveform. If you did, okay, all right, patient should probably be feeling better. It looks like the medicine's kicking in. They're ventilating a lot better now. So look at the waveform to see if your treatments are working or if you need to give more. Asthmatics, remember what I said, initially they're gonna be hyperventilating because they can't breathe. So you're gonna see a low end-tidal CO2 on these patients. If you start to see that end-tidal CO2 starting to go up, the patient's getting tired, he's slowing his breathing down, he needs help. So keep that in mind. On your altered mental status, overdose patients, it'll help you determine if you need to intubate them or get aggressive with the airway or not. See how well they're ventilating with their end-tidal CO2. If their end-tidal CO2 is staying normal, their O2 sats are staying normal, okay, I think I could probably watch them. You start seeing their O2 sats drop, that's one thing. If you start seeing their end-tidal CO2 starting to go up, that means they're not breathing enough. You need to probably start assisting them with a little bagging, help them get full deep breaths. Use it to determine if there's any obstruction in your airways, or if your airway got displaced, right? Look at the waveform. You had nice rectangular waveforms on that pneumonia patient that was intubated. Now all of a sudden he's got these weird triangle-shaped waveforms. Huh, what's going on here? You take a look, well, the tube's still in place. Maybe I need to suction him out. You suction him out and pull out a big old mucus plug, and now all of a sudden he goes back to rectangular. Okay. When you're bagging patients, how do you know if you're bagging too much or not enough or what? Bag them. Use the end-tidal CO2 to bag them appropriately. If you got a DKA patient, what do you need? You need to hyperventilate them, right? You want them breathing faster because you need to help them blow off some of this acidosis. Hyperventilate them. You know, use your end-tidal CO2 to know that you are keeping it down. You want to keep it a little bit on the low side if you know they're acidotic. Use it to grade your CPR. Okay. Make sure you're doing adequate compressions at all times and to know when it's time to switch. When that end-tidal CO2 starts dropping below 15, switch, okay? Or push harder. And use it to adjust your vent settings, okay? So I'm gonna go through a couple of them. And these are just, you know, weird ones that you might come across, but this is an example of, let's say you intubate somebody or somebody's intubated at a facility, you pick them up, and you're seeing this kind of waveform when you hook them up. Most ERs don't even have capnography. Is there any ERs that are using capnography that you guys have been in, where they had a waveform going and?
Some have the ability to get it for maybe a single monitor, but it's not set up all the time.
But there's not very many. So, you know, you're gonna see an end-tidal CO2 waveform when you hook them up that they never saw, and you see something like this or a funky waveform, you probably need to be like, hey, can y'all check that too, because this waveform isn't right. And what this is so the patient is intubated, but they've intubated too deep. They're slightly on the right main stem, and what you're seeing is this is the right lung exhalation, and then you see this because this is from the left lung. You're not getting both lungs exhaling the carbon dioxide at the same time through the detector. You're getting this kind of humpback feature there. What's this?
Shark fin.
Shark fin. What does that mean?
Bronchospasm.
Asthma, yeah, bronchospasm, right? So you're going to treat that, and you're going to see it as they're opening up. You'll see it go back to a rectangular waveform. Securare clef. You guys ever heard of this one? This is where you got a patient, they've paralyzed them, they're intubated, and the paralytic is starting to wear off. And so now what you're starting to see, you know, a normal patient, human reflex is to try to take a breath. So they're still paralyzed, but not completely. they have a very weak inspiratory effort right here, but it's not very much. Very shallow breathing there, so you see these little clefts. So what do?
Sedate them, sedate
Give
them,
them some medicine.
sedate them.
Give us another fairly, our practice is to paralyze them, but you want to do is sedate them.
Sedate them.
Okay, and this is why, because just imagine being awake and paralyzed for a second here, and having a tube down your throat and a machine breathing for you. It's not a very pleasant thing to think about. So we should probably get into the habit of using sedation rather than paralytics, okay? This is a reversal of your normal rectangular waveform in an emphysema patient. Why is that? What happens in emphysema patients? They don't have that elasticity in their lungs, right? Their lungs can't exhale. They're able to breathe in, all this air comes in, but then they can't fully exhale because they damage their lungs to where their lungs won't recoil back. So what happens to them is the exact opposite. They initially get their highest level of carbon dioxide off, and then they can't get the rest of it off, so it drops down. So if you see that in one of these older patients that has emphysema really bad, don't be surprised. That's normal. What's this?
This place too.
Yeah. This is a date with Dr. Desai. If you didn't know that, okay? That is what you will see when you intubate the esophagus. You'll have a flat line, with these little bitty squiggles, but you're not going to have a value and you're not going to have a waveform. You better pull that tube, or you better make sure the patient has a pulse if you know the tube is in the right place. Okay? What's this one? That's the esophageal tube, right? Yeah. Another one. That's just two examples of what you can get most of the time, or what you might see. So this is an example of rebreathing. So when you're inhaling, you should always be at zero. There should not be any carbon dioxide in your inhalation unless you're breathing from an exhaust pipe. But if you got a patient on a vent, or you're bagging them, and if you're giving him a bag, or the vent's inhaling for them before they're fully exhaling, what's going to happen? They're going to start retaining carbon dioxide because they're not getting a full breath out. And what you start seeing is an elevation in their carbon dioxide levels slowly. It just gets higher and higher and higher until it's going to become extremely difficult to bag the patient because you're not letting them exhale. So what do you need to do at this point?
Let them exhale.
Take it back off. Yeah. Disconnect them from the vent, disconnect them from the bag, and you can even sometimes put a little pressure around their ribs to help exhale all the air out. Let them get a full exhalation, and then make sure that your baseline goes back down to zero. Okay. So this is an example of a partial obstruction. See how it looks just like a shark fin, kind of triangular shaped shark fin? Because partial obstruction of an ET tube or an airway, it's kind of the same as having a bronchospasm, right? You're not able to get the full air out, so you see this very slow rise to the peak end-tidal CO2 right there. And this is something that is also a normal pattern, and this is something that you should see in pregnant patients.
You should, but you don't.
Or in very obese patients. And what this is in pregnant patients, or sometimes in morbidly obese patients, their lung capacity is very diminished, right? They're unable to take full deep breaths, and whatever air they are getting in, what happens is either, the patient has an enlarged uterus that's pushing up on their lungs, or there's a lot of weight surrounding the chest wall. All that pressure causes those alveoli to collapse very quickly, and you get this surge of carbon dioxide that gets pushed out of their alveoli at the very end of exhalation, as the weight is causing all those small bronchioles and alveoli to completely collapse. So that's why you see this, that's why you should see this uptick all of a sudden in these patients. And it just means, hey, they might be pregnant, or they're just morbidly obese. Doesn't mean there's anything wrong with them. Or if you don't see that, they may not be pregnant enough, right, Bethany? We tried this with Bethany, but she wasn't, couldn't get it right.
She messed it up.
So now that you guys are thoroughly confused and are never probably going to use end-tidal CO2 again because it makes no sense, I got a couple of shout outs because I know end-tidal capnography is kind of intense, it's kind of confusing, but I hope that helped clarify some of the misconceptions on how you should utilize it. I think it's very easy to get into this mindset that, oh, you need to do something with the pH because the end-tidal CO2 is this. No, that's not how it works. Mike brought up to me that, you know, you're working on cardiac arrest and you're looking at the end-tidal CO2 and it's 15. And there's this misconception that, oh, I'm bagging them too much, I need to slow down. No, you need to bag them 12 times a minute. The reason their end-tidal CO2 is 15 is because they're hypoperfusing. Okay, so keep that in mind. Remember, look at your patient from a full standpoint. Don't just look at one thing. So I hope this helped clarify that a little bit, did it? Hopefully. If any questions on capnography, does anybody have any questions? What about on Facebook? Anybody got any Facebook questions?
There was one question back when you were talking about the tube, the little wave that where the tube's not, it's been slightly dislodged.
Mm-hmm.
Would they see something like that with the iGel, or is it that was the question.
Well, so the iGel, you might just see complete loss of waveform because it's not specifically within the trachea, right?
Mm-hmm.
But they may see a change in their waveform because it's not getting the full exhalation of the end-tidal CO2. So you may potentially see that.
Okay.
Yeah.
All right.
I wanted to ask, with the way that the CO2 is sometimes helpful. So if we have a pneumonia patient, for example, we want to see if evidence of bronchospasm is present, see if like albuterol might help. I know that currently we have the inline. We can kind of have the patient try to blow into that. Would it be an option to get nasal cannulas with the end-tidal back? The cost on those has dropped. They only cost $1.91 more than our inline end-tidal. So it's not really adding much cost. So I just wanted to check if that might be an option.
Yeah, so the question was, can we get the nasal cannula capnographs? That's something that Greg LeMay and I have actually been looking at, and you know, I like it more and more as long as they're used responsibly. Okay, because they are, I think we had it many years ago, Don Elder was telling me about it, but the problem was people were just throwing them on everybody. Oh, you need the little nasal cannula oxygen, all right, let's put the capnograph cannula on them when you don't necessarily need it on everybody. But you're right, the cost has significantly dropped to the point where it's not significantly much difference between what we have now and having one of those. So I think that's something that we will probably definitely be entertaining. Yes?
Regarding your bullet point, putting it all together about the head bleeding, keeping a normal end-tidal CO2, we're talking absence of evidence of brain herniation?
Yes. So in a head bleed patient, if you're hypoventilating the patient, you're not bagging them enough, and their carbon dioxide is starting to build up, what you're going to see is vasodilation of the cerebral blood vessels, and it increases blood flow to the brain, which is not good if you're bleeding in the brain. And if you're hyperventilating them, which means your end-tidal CO2 is going to be low, that's also not good, because what that tends to do is cause vasoconstriction to the blood vessels in the brain. And that's not good because the brain needs blood flow. So that's why you want to keep it just right between 35 and 45. Of course, if there's potential signs of herniation, that's when you do hyperventilate them and you try to blow off some of that CO2, because if they're herniating, you want to decrease some of the pressure in the brain by hyperventilating them, blowing off that carbon dioxide and causing vasoconstriction. But yeah, in a normal head bleed, you want to try to, and that's a very sensitive thing of keeping that CO2 in the right range, because you can really hurt a patient with a head bleed if you're one way or the other. What else? No other questions? So real quick, you know, we all work as healthcare providers. We want to give a shout out to that toe pain that ended up being a STEMI. I know we've all had those, right? You get them over there and all of a sudden they change. Shout out to all our regional directors, our supervisors. Okay.
That's so true, Hayden.
Shout out to all our probies. Yeah. You guys be careful, even our non-probies, be careful, Dylan. Shout out to our nurses. We have any nurses?
They left.
No,
They
no, we
left?
have one.
We have a nurse, okay. Shout out to our nurses.
That's so true. That's true.
And then, of course, shout out to the mothers. That's it.
All right.